Hi, my name is Jordan Avery. The female reproductive system is coordinated through the regulation of hormonal feedback loops. Key components in these feedback loops involve communication between the hypothalamus, pituitary gland, and ovaries. Feedback loops are critical for regulating the cyclical sequence that occurs every 28 days of follicular development, ovulation, and the formation and degeneration of a corpus luteum repeated in the menstrual cycle. The first 14 days of the menstrual cycle involves endometrial sloughing in a non-gravid female and follicular development, with estrogen as the dominant steroid hormone. The last 14 days of the menstrual cycle are dominated by the luteal phase and the hormone progesterone. At the midpoint of the cycle, between follicular and luteal phases, ovulation occurs, triggered by surges in LH. The hormones that regulate this process are found in the hypothalamic pituitary ovarian HPO axis. Gonadotropin releasing hormone, GRH, hypothalamic hormone, drives ovarian function through pulsatal activity. When GRH levels are sustained at high levels, it downregulates receptors in the anterior pituitary. GRH stimulates the release of gonadotropin hormones, follicle stimulating hormone, FSH, and luteinizing hormone, LH, which act directly on the ovaries to regulate follicle development and ovulation. The main gonadotropin hormones involved in the female reproductive system are estradiol, progesterone, and inhibitory hormones include the class of inhibins A and B. The gonadal hormones exert feedback to alter the secretion of GRH, FSH, and LH in a long loop response. When circulating levels of steroid hormones, progesterone and estrogen, are low, the pituitary secretes FSH and LH. In females, the presence of steroid hormones, specifically estradiol, exerts both positive and negative feedback. The cycle begins with menstruation as day 1, and this triggers the early follicular phase. The early follicular phase is marked by a rise in GRH due to low levels of estradiol and progesterone. Low frequencies of GRH pulses are present and favor FSH secretion. FSH acts directly on granulosa cells to stimulate the recruitment of new follicles and to promote the synthesis of estradiol via aromatase. Locally produced estradiol supports the effects of FSH, creating a reinforcing cycle. More granulosa cells leads to more estradiol production, which in turn stimulates further follicular development. With low levels of estradiol, FSH secretion is upregulated while LH remains low. This prevents premature ovulation. Estradiol dominates this phase and exerts positive feedback onto itself to drive cell proliferation. This is regulated by some of the inhibins hormones. As estradiol levels rise, it induces a change in the pattern of hormones to drive ovulation, seen in the later follicular phase. Granulosa cells continue to multiply, and a distinct layer of theca cells forms outside the follicle. At this stage, the follicles are classified as secondary follicles. As estradiol levels rise significantly, they set the stage for ovulation by switching feedback mechanisms. High-frequency GRH pulses favor LH secretion, which eventually triggers ovulation once the follicle is mature. The feedback mechanisms of estradiol shift, resulting in a decrease in FSH and an increase in LH. This is primarily driven by the different concentration levels of estradiol and it increasing. With lower levels of FSH, cell proliferation is primarily driven by the positive feedback that estradiol exerts on itself. Again, inhibitory hormones such as inhibins prevent overproliferation. As the follicular stage nears its end, about 12 to 36 hours before ovulation, estrogen secretion reaches its maximal levels. By this time, only one dominant follicle is developing, and it begins to secrete progesterone and estrogen. Persistently high levels of estrogen lead to a dramatic increase in LH secretion, called an LH surge. The LH surge induces ovulation by triggering the mature follicle to rupture and to release its oocyte into the fallopian tube. Following ovulation, the ruptured follicle transforms into the corpus luteum, which secretes progesterone and estradiol. Progesterone plays a crucial role in preparing the endometrium for potential implantation by thickening the uterine lining. Both progesterone and estradiol provide negative feedback to the hypothalamus and pituitary, inhibiting the release of GRH, FSH, and LH, thereby preventing further follicular development and ovulation. If pregnancy does not occur, progesterone and estradiol levels decrease, and the hypothalamic pituitary hormones increase, leading to the resumption of the cycle. If pregnancy does occur, progesterone levels remain elevated to support the maintenance of the endometrial lining and to prevent the shedding of the uterine lining. The corpus luteum would continue to produce progesterone until the placenta takes over this function, effectively halting menstruation. Dysregulation of the feedback loops in the female reproductive system can lead to a variety of disorders that affect menstrual cycles, fertility, and overall reproductive health. These disruptions often stem from hormonal imbalances that interfere with the normal functioning of the HPO axis, which coordinates the release of hormones necessary for regular ovulation and menstruation. Hormonal imbalances between LH and FSH can be seen in disorders such as polycystic ovary syndrome, otherwise known as PCOS. In PCOS, LH levels are abnormally high and FSH levels are low. This creates a disruption in the normal hormone balance. Due to elevated levels of LH, which promotes ovulation, and low FSH, which promotes follicle maturation, the ovaries develop immature follicles that do not ovulate, and ovulation occurs, meaning no oocyte is released during the menstrual cycle. This leads to irregular periods or absent periods because ovulation is not happening as it should. High LH also overstimulates the ovaries, causing them to produce testosterone and other androgens in excess. Another disorder called premature ovarian syndrome, POI, is a condition where ovaries fail to respond to the signals from the pituitary gland. The ovaries lose their normal function before the age of 40, leading to reduced estrogen production and irregular or absent menstrual cycles. Normally, when estrogen levels are low, the pituitary gland increases the release of FSH and LH to stimulate ovarian function. However, in POI, the ovaries no longer respond to these hormones, even when FSH and LH are elevated. As a result, negative feedback is disrupted. The hypothalamus and pituitary continue to release high levels of FSH and LH in an attempt to stimulate the ovaries, but the ovaries are unresponsive, leading to a decrease in estrogen levels. Consequences include menstrual irregularity, infertility since ovulation is impaired or due to anovulation, and menopausal symptoms. In conclusion, the female reproductive system operates through intricate hormonal feedback loops. Disruptions in these feedback mechanisms, such as seen in conditions like polycystic ovary syndrome and premature ovarian syndrome, can lead to significant reproductive health issues, including irregular cycles and ovulation and infertility. Understanding these hormonal interactions is critical for diagnosing and managing reproductive disorders and for supporting women's overall protective health. Proper regulation of the hypothalamic pituitary ovarian axis is essential for maintaining fertility, menstrual regularity, and overall well-being.